Hey everyone, this is Unit 8, Lecture 2. It is all about anxiety disorders and obsessive compulsive disorders and those that are related, and stress-related disorders. I will show you in just a minute as to why all of these are treated as the same category, sort of. Here are our learning targets, which will actually come back up for other lectures as well. So as I said in Lecture 1, you do not need to know statistics, but I think the statistics are important to help you wrap your mind around the importance of this unit and these disorders and understanding this topic. So according to the Anxiety and Depression Association of America, anxiety disorders are the most common mental illness in the U.S., affecting 40 million adults ages 18 and older every year. This is about 18% of the population every year. And according to the National Institute of Health, now this is based on the DSM-4, so it's slightly dated, and this statistic could be a little different, but an estimated 31.9% of adolescents, so people between 13 and 18, have had an anxiety disorder. That's a lot. Why is this important? To tell you and make you realize that this is everywhere, and that if you are experiencing this or someone around you is experiencing this, it's not that unusual. And I even have a slide of celebrities that have publicly announced that they have or continue to struggle with anxiety disorders. Why does this matter? Why do we care if celebrities have mental disorders? Because it's an example of how successful you can still be in your career and in family and friend and social relationships, even if you have one of these disorders. Okay, so I mentioned on the title slide, the idea of these categories being a little bit different than maybe they once were. In the DSM-4, anxiety covered all of these types of disorders, but in the updated DSM-5, anxiety now covers these 3 disorders, and then obsessive compulsive and related disorders and trauma and stress related disorders now have their own separate category. So we have fine-tuned the definition of these categories. Let's start with anxiety, the 3 anxiety disorders. You do not need to know every single symptom of every single disorder that I'm going to talk about, but try to pick out a couple key ones, and I'll make sure to point out anything that I think is super important to write down. So some general qualities of anxiety disorders: worry, fear, apprehension, intrusive thoughts, physical symptoms, and feelings of tension. And that these feel like they are automatic. They are not under the person's control who is experiencing them. It feels like a knee-jerk or involuntary reaction. And because they can't get control of it, it will create even more anxiety. So let's take a look at the first one. General anxiety disorder. This is intense, prolonged, vague, and unexplained anxiety. Here's what's the key on this one besides the intense, prolonged, vague, and unexplained symptoms. The anxiety, the fears, do not seem to be attached to a particular object. So someone is worried in general, and they can't even express why. They cannot pinpoint, like, if I fix this thing, my anxiety will go down. It's this constant feeling of worry. Studies show that between 4.1 and 6.6% of the population experiences this one, that it's more common among women than men, and that it tends to emerge or become evident between the late teens and early 20s. This one's also one of the controversial ones that critics of the DSM have said, doesn't this just define everyone all the time? And what's the difference? Here are some features that try to distinguish it as different than your average person's type of worry. That it is excessive, and that it maintains its presence in someone's life for at least 6 months, and that it is causing considerable distress or impairment. So it is interrupting daily life, socially, in their jobs, in other important areas. Perhaps they are restless. They are easily fatigued. They have difficulty concentrating. Their mind goes blank. Maybe they're irritable. Maybe they have muscle tension. They are unable to control the worry. It might keep them up at night. So all of these different things, again, just pick a few of these to write down. This is what separates out general anxiety disorder from simply someone who's having an anxious moment. Panic disorder is similar to general anxiety disorder, except the symptoms are greatly magnified, and there is a more sudden onset. So instead of this like slow, low burn of anxiety. There might be a recurrent and unexpected panic attacks, specifically that arise within a 1 month period or longer. I have had, I think, maybe 2 panic attacks in my life. I would not have this disorder because it does not come up over and over and over for me. And I do not live in worry of the next attack, because that's another quality, that even if you're not having an attack, you have persistent concern that an attack could come. So how do you know if you're having a panic attack? Here are some symptoms. Again, pick a few to jot down. Shortness of breath, feeling smothered, feeling dizzy, unsteady, or faint, trembling, shaking, sweating, having a racing heartbeat, choking, nausea, some stomach pain, a sense of just strangeness. You just feel weird. You might fear that you're going crazy, or you're losing control, or dying. Perhaps you have numbness or tingling, chest pain, overall discomfort, and that the duration of the attack and the severity often varies. So these are not even something that are the same for everybody who experiences them. So again, a panic disorder includes panic attacks, or the fear that panic attacks are coming. Moving on to phobias. Phobias are marked by a persistent and irrational fear of an object or situation that disrupts behavior. So here's the thing. This little graphic here shows you how many people are afraid of the same thing. That's that blue bar on our bar graph here. Many, many people are afraid of things like flying, blood, height, animals, and so on, that sort of thing. But to have a phobia means that it's not logical, that that it's disrupting your life and your ability to do things you need to do, and that it's always there. So I can say that I'm afraid of bees, but I'm not constantly afraid of bees. But if one is near me, yeah, I might kind of shudder or feel the EBGBs, but it's temporary and it does not stop me from going about my life. To someone who might have an actual fear or a phobia of bees, they might just always feel like they're around. And it's preventing them perhaps from attending like a party in the summer, or going to a water park, or even just spending time outside in their garden. So it's disrupting their daily lives. There are 3 kinds of phobias that we are going to focus on. First of all, there are specific phobias like the fear of flying or fear of snakes or something like that. So those are phobias that are linked to a particular object or event or situation. Social phobia is when you have a fear of embarrassment in interacting with others. So perhaps you have a fear of public speaking, or perhaps you feel anxious when you have to go to like a big family Christmas party or some other social situation. And so it's not that you're afraid of the people themselves, you're afraid of embarrassing yourself in front of others as you interact with them. Agoraphobia is different. And some people think agoraphobia is just fear of crowds. That's not it. It is almost like you have fear of fear itself. Like you have fear of becoming afraid in public, and so you never leave your house. You're afraid of encountering a situation that's going to set off your phobia. So it's a fear of entering fear-evoking or unfamiliar situations, which often accompany panic attacks. And so you might stay home. Yes, you might avoid crowds and social situations, but you're doing that to avoid something that could trigger an attack. So you're not afraid of the crowd itself. You're afraid of venturing out of your home and then having a little phobia attack when others are around and you don't feel safe. Moving on to obsessive compulsive and related disorders. We like to casually say frequently, oh, I have OCD, or that's my OCD speaking. Yeah, that's a thing, but we definitely overuse that phrase. Let's talk specifically what it is. It is persistence of unwanted thoughts and the urge to engage in senseless rituals that cause distress. It is important to know the difference between obsessions and compulsions. The obsessions are the thoughts. It's the persistent, the constant thought of being afraid of, say, germs or the safety of your house, like locking doors. But then the compulsion is those rituals to address those thoughts, like washing your hands frequently or checking the locks on your doors frequently. So persistence of unwanted thoughts, those are the obsessions, and the urge to engage in senseless rituals, those are the compulsions, that causes distress. That's the common theme. This happens so much. These obsessions occur so often, and you do these rituals so often that it's disrupting your daily life and you don't like it, but you can't stop it. People with OCD don't trust their senses or their decision making. So even if they think they remember locking the door, or they think that they are in a safe household where it's okay to touch the doorknobs, they don't trust that. They don't know anything with certainty, so they do it over and over again. That they do the ritual, the compulsion over and over again, because in a way, better safe than sorry. So it's a cycle. There's an obsession, there's an intrusive thought, and then there's anxiety or stress that's related to having that obsession. And so to relieve that stress, someone engages in a compulsive ritual and then they feel better. But it's just a matter of time before that thought comes back, and then it repeats over and over and over. So what part of the brain, think about this as we review our brain, our lobes, and the different structures in our brain. What part of the brain would a biological psychologist say is affected by OCD? It is the frontal lobe. Our frontal lobe has to do with planning, judgment, and attention. And this is a PET scan of a brain of a person with OCD, and those red areas are the high metabolic activity areas. Remember, PET scans, you inject someone with radioactive glucose, and then as they break it down, as they use it, it will show up in different degrees on a scan. And so what this indicates is that there's high metabolic activity in areas of the frontal lobe involved with attention. Here we have 4 OCD related disorders. It is okay to pause me and write all of these down, but then make sure to unpause me and hear me out, because I'm going to add a couple qualities to each one that aren't actually on the screen that hopefully will just help you understand this. So body dysmorphic disorder. This is preoccupation with an imagined or exaggerated defect in one's appearance. The essential feature here is that imagined defect. It's not actually there, but being essentially obsessed with that. I'm going to talk more about this one in just a second. Hoarding disorder. This is persistent difficulty discarding or parting with possessions because of a perceived need to save them. And you feel extreme distress at the thought of getting rid of them, whether donating, throwing away, whatever, just getting rid of them. Trichotillomania is the recurrent irresistible urges to pull out hair from your scalp, eyebrows, or other areas of your body despite trying to stop. This is also more casually known as hair pulling disorder. And then excoriation disorder. This is repeated picking at your own skin, so much so that it's resulting in skin lesions and abrasions. So skin picking disorder. And all of these cause distress. What does that mean? It means it's so much so that it's disrupting your daily life. So you might think like, oh yeah, I totally think that my nose is shaped funny. I don't know. That's one of my things. I think my nose is shaped funny. Or, oh yeah, I hate to get rid of my childhood toys. Or, yeah, like when I have like a pesky hair, I just pick and pick. And so on and so on. That's not what I'm talking about. I'm not just talking about these things. Like all of us probably experience this in a very mild way here and there. But this is where it is constant. It is so constant that it might be disrupting your ability to have friendships, your ability to have relationships, your ability to go to your job or to go to school or complete something successfully. I'm going to go into a little bit more detail with BDD only as an example of the complexity of these disorders, but this could be applied to any of the 4 I just mentioned. So this is distress over a supposed deformity. It's not actually there. There's not actually a defect. It's in their mind. It's usually about the shape or size of their facial features, acne or spots on their skin, wrinkles, thinning hair, and scars. And I am not talking again about ordinary fears or self-consciousness about these things that a lot of people experience. It's so bad that it may lead to avoidance of work or public situations. And it is linked to higher rates of major depression and suicidal tendencies, and it becomes evident in adolescence and affects males and females equally. Here is an example of what those with BDD see when they look in the mirror. So this might be closer to accurate, but then this is how they may draw themselves and then analyze themselves or pick themselves apart. Okay, on to trauma and stress-related disorders. The most well-known is probably PTSD. And I would like to mention that we often associate this with soldiers who have come back from combat situations, but it is becoming more and more understood that it can be a result of all sorts of different types of trauma. Some of the symptoms: haunting memories, nightmares and flashbacks, social withdrawal, jumpy anxiety, and sleep problems. And 4 or more weeks of these symptoms is how one might be diagnosed with PTSD. Only about 10% of women and 20% of men react to traumatic situations, combat or other, and develop PTSD. And there are even examples of people that face, I don't want to say even worse, but terrible situations like Holocaust survivors who have shown remarkable resilience against traumatic situations. So it is definitely possible for someone to experience a trauma and not develop PTSD, but some may also develop acute stress disorder. What's the difference? It is very similar to PTSD, but it starts more immediately after the trauma and lasts from 3 days to 1 month. So post-traumatic stress disorder, PTSD, tends to be a little bit delayed and lasts longer, sometimes for years and years and years. This was previously considered just part of the general anxiety disorder category, but it is now acknowledged that there might be anxiety in acute stress disorder, but not always. Someone also may experience anger, aggression, or dissociation, and that is a word. It's almost like a break from your personality. We'll get way more into that word later. Take a look at 2 different perspectives as to how or why anxiety disorders and the like develop. The first one we're going to look at is the learning perspective. So most likely your behaviorists, but also possibly your socio-cognitive thinkers. Learning theorists suggest that fear conditioning leads to anxiety, and that this anxiety gets associated with other objects or events through stimulus generalization and then gets reinforced. So let's say perhaps early on someone yells at you a lot not to go near a pool. You could drown. Don't go near there. Don't go near there, as a child. So over and over. Don't do that. Don't do that. Don't do that. Maybe over time it leads to anxiety over all bodies of water, because you've been yelled at so often to not go near a swimming pool that now you can't go near a lake or a river, or heck, maybe even it goes so far that you become afraid of bathing because you got yelled at and scolded every time you got near that pool in your backyard. Also, the learning perspective includes social learning, that fear responses often develop from observation. We have evidence in this that young monkeys, even when raised in captivity and not in the wild, will develop a fear of snakes when they watch other monkeys fearful of snakes, even if they personally have never encountered a snake. The biological perspective states that generalized anxiety, panic attacks, and even OCD is linked with a certain brain circuits malfunctioning in the anterior cingulate cortex. So that it is not, that is one thing that they've been able to tell in the brain, that this is an area of the brain that is different compared to someone that does not have one of these disorders. All right, that is it for anxiety disorders and the like.